Rob's a trainee from North East Thames, the other side of the tracks, and he's going to give us a talk about ongoing work and his planned work for his thesis entitled Optimising endoscopic management of large colorectal polyps. So I'll hand over to you, Rob.
The title of my thesis and of this talk is Optimising endoscopic management of large colorectal polyps. My supervisors, Dr. Adam Humphreys and Professor Brian Saunders. So what we're going to talk through today is a little bit on the background of my research. We'll then outline my thesis and the projects involved, and then hopefully we'll have some time for feedback and questions at the end. So these are well-trodden statistics now, but we know that colorectal cancer is the third most common cancer in the UK, and we know it's the second most frequent cause of cancer-related mortality. And the overall incidence is actually increasing. So if you look at these statistics on the right, from the Global Cancer Network, so in Europe, by 2050, colorectal cancer will have overtaken breast and stayed ahead of lung as the most common cancer in Europe. And actually interesting, this is being driven by a rise in younger patients. This is data from the US actually, and showing that the incidence in those aged 65 and above is decreasing. The incidence in those between 50 and 64 is pretty static. But actually the rise is in the incidence between 20 and 49. And obviously there's some kind of epidemiological risk factors driving this, but there's probably also a contribution from screening colonoscopy. So we know that screening colonoscopy with endoscopic resection reduces the incidence and mortality of colorectal cancer. This is illustrating the statistics on the right. But obviously, as yet, only screening populations have been generally above 60, and obviously that's reducing now down in the UK. So the title of my thesis, as mentioned at the beginning, is Optimising endoscopic management of large colorectal polyps. And the questions I think to be answered are, what are we doing at the moment? How are we performing? How can we improve our current practice? And what is the future of endoscopic resection? So my thesis outline, I think, can be nicely summarized with this well-known chocolate biscuit, but rather than picking up a penguin, we're looking at the patient, the polyp, and the procedure. Okay. So starting with the patient, and to steal a phrase from my own supervisor, Professor Saunders, remember the whole patient, not just the hole in the patient. So how do we select which patients should undergo endoscopic resection? Or in other words, should we be doing anything at all? Now, there is some expected guidance upcoming from Matt Rutter and the BSG on whether to start investigating the elderly or the comorbid for polyps and colorectal cancer. But actually, we often receive patients much further down this diagnostic pathway, and they already have confirmed advanced pathology. Or as Dr. Latchford likes to say, they're well on the way at the sausage factory of the 2-week wait pathway. We know that endoscopic resection of premalignant polyps reduces the incidence of colorectal cancer, but obviously this only matters if the patient is actually going to live long enough for this to happen. And we know that progression of polyps to cancer is slow. So this is quite old data now from the 80s. But they carried out radiological surveillance of polyps greater than 10 millimeters. And actually you can see here that the progression to cancer is slow. So only 2.5% at 5 years and 8% at 10 years. So it takes quite a long time for these medium to large size polyps to become a cancer. So what guidance do we have? Now, the BSG does have some guidance on when to stop post-polypectomy surveillance, although it is pretty vague. So they say, in general, we recommend no surveillance if the life expectancy is less than 10 years, or if older than about 75 years. But actually, there's no formal guidance on whether we should start this polypectomy process in the beginning. An age cutoff of 85 years has been suggested, but actually there's no strong data to back this up. And it takes no consideration for comorbidity. So moving on to comorbidity, I'm sure we're all quite well versed with the Charleston Comorbidity Index, but just to recap, this was developed in the 80s and amalgamates a list of comorbidities and is used to estimate 1 and 10-year mortality. And it has been validated in many different populations, including colorectal cancer, as you can see here on the right, with those with a Charleston comorbidity score greater than or equal to 2, having worse outcomes when undergoing colonic resection for colorectal cancer. But the Charleston Comorbidity Index has not been validated in endoscopic resection of colorectal polyps. But we do know that older and more comorbid patients do have worse outcomes. And this is a large study from California where they looked at 250,000 colonoscopies, and they found that increasing age, increasing comorbidity, again defined as a Charlson Comorbidity Index greater than or equal to 2, or the performance of invasive interventions, namely EMR and ESD, were all significant positive predictors of perforation during colonoscopy. And even during diagnostic colonoscopy, so not performing any intervention at all, this study also showed that for each year of age, there was a 1% increased risk of perforation. And then what data do we have from this country? Well, there's a small study from Liverpool where they looked at 200 patients over the age of 75 who underwent EMR. And actually, a good proportion of them had good-sized polyps, so greater than 50% had a polyp greater than 20 millimeters. They had a very low overall complication rate of 1.6%. But actually, the mean overall survival was not very impressive, with only 6.7 years of those over 75. And they only had one colorectal cancer-related death. And you can see here on the right, they did show that an age greater than 80 and a Charlson Comorbidity Index greater than 2 were independent predictors of significantly shorter survival. But what about the patients who are referred for surgery or conservative management? Because this is only a proportion of the patients with advanced polyps who actually end up undergoing endoscopic resection. So that led us to do some work last year, which we presented at ESG Days, where we looked at our experience of patients over the age of 85, who referred to our complex polyp meeting. So the retrospective study, we found 54 patients identified between 2017 and 2022. 21 of those were referred for endoscopic resection, but a good proportion, 25, were managed conservatively, and 5 were referred for surgery. Complication rate was higher than Liverpool in the endoscopic resection group, and that was 11%, and that was all bleeding. So that was reattendance to hospital requiring blood transfusion or a repeat procedure. There were no perforations, and there were no deaths secondary to complications. And in fact, when you compared the endoscopic resection group and the conservatively managed group, there's increased mortality in the conservatively managed group at 16 and 69% for 1 and 3-year mortality respectively. But in either group, we had no deaths secondary to colorectal cancer. And actually, on retrospective applying comorbidity index, we weren't doing this at the time. There was no difference between the endoscopic resection group and the conservatively managed group. So what does this tell us? Well, it tells us that at that time, we were probably selecting the patients for an intervention and those for conservative management appropriately. But actually, if we had been using a comorbidity index, it probably wouldn't have helped us. So there's something else that we're not taking into account, whether that's frailty, whether that's patient wishes, or just clinicians' kind of inherent view on whether we should go ahead, that is perhaps more significant than their Charlson comorbidity score. So moving on to the polyp, and here we have the ESG guidance on polypectomy, which Caio and the endoscopy fellows presented a couple of months ago. And the first stage of this algorithm is to assess the polyp. And particularly for the high-risk lesions, we're looking at those that are greater than 20 millimeters. But why are we interested in those polyps? Well, we know that greater than 20 millimeters, you have an increased risk of submucosal invasive cancer. But interestingly, we also know you have an increased risk of unintentional piecemeal resection. And we know you have an increased risk of recurrence. In addition to size, it's well known that site and morphology can be used to predict submucosal invasive cancer. So here's some data from the Paris group where they used size and morphology, and they showed that with increasing size, and particularly a 2C, that's a depressed component, or a large sessile component, a 1S, there was increased risk of malignancy. Using site and morphology, the Australian group showed that particularly non-granular lesions in the distal colon carried a much higher risk of cancer. And then combining size, site, and morphology, the Italian group showed that particularly large lesions in the rectum with a multinodular appearance greater than 4 centimeters carried the highest risk. But actually, size, site, and morphology only takes you kind of halfway down the algorithm. And before you can consider whether something is potentially endoscopic resectable, and particularly what the plane you should be hoping to resect that polyp in, you need to work on advanced endoscopic imaging. So what is that? So John Landy presented this in a little bit more detail last month when he was talking about T1 cancers, but there are a number of classification systems we can use looking at the surface pattern of polyps to try and predict the underlying histopathology. So the Kudo classification is perhaps the most well known, and it can differentiate between benign lesions, superficial submucosal invasive cancer, and deep submucosal invasive cancer. But its main drawback is it requires magnifying chrome endoscopy. And this is something which is not readily available in most parts of the world. It means it's quite not very accessible, particularly in the UK. So perhaps more accessible is the NICE classification. So this uses narrowband imaging. So this is a technology that is on all of our modern endoscopes. And this is good at excluding deep submucosal invasive cancer, so with a negative predictive value of 98%, and that's the type 3 pattern seen on the right here. But actually it cannot differentiate between low-grade dysplasia, high-grade dysplasia, and superficial submucosal invasive cancer. So all three of these histopathological subtypes all fall into the type 2 category. So it's good at telling you whether you can remove a polyp endoscopically, but it doesn't give you any advice on what technique or what plane you should be working in. A little bit better is the JNET classification. Again, this uses NBI. And the key here is it can differentiate between shallow and deep submucosal invasive cancer. So this is between type 2B and the type 3 lesions. However, particularly in the type 2B, which are kind of the ones we're really interested in, it does have a low positive predictive value, dysplasia or superficial submucosal invasive cancer. So, as with most things these days, and particularly in medicine, can AI help us in identifying these high-risk polyps? So Rowan Kader gives a nice kind of tour de force on AI applications in endoscopy a couple of months ago. So far, most of the work has focused on computer-aided detection, so that's CAD-E systems, as seen on the right. So during withdrawal, you get this nice green box, which highlights where the polyp is, and then advises you to remove it. There's also computer-aided quality assurance, again seen on the right. So this gives you, the one here can give you real-time assessment of your KPIs. So here it's telling you how much mucosal exposure you've achieved and whether you should go back and have a look at something that you may have missed. And the last one, the thing that we're really interested in, is computer-aided diagnosis, so CAD-X, and that hopefully gives you a real-time pathology. Now, so far, this is largely focused on small polyps. So on the right, we've got a video from Olympus and Odin Vision, and this combines a CAD-E and a CAD-X system. So it highlights the polyp, and also at the top, you can see it says non-adenoma. Again, we've got another non-adenoma highlighted here, and then we've got an adenoma here highlighted. But so far, this is largely focused on small polyps, either as part of a diagnose and leave strategy in the rectus sigmoid, or as a resect and discard strategy. But what we really want is an AI to help us with therapeutic endoscopic decision-making. Now, there have been a handful of studies looking at CAD-X to differentiate between superficial and deep submucosal invasive cancer. And these have shown that the CAD-X can outperform novice endoscopists, but none of them have shown that actually the CAD-X can outperform expert endoscopists. I think this is really the key thing, because it's the expert endoscopists who are going to be involved in resecting these high-risk lesions. And none of these systems have been validated in a real-time clinical setting. So what we're looking to do is the reliable estimations for safer endoscopic cancer therapy with artificial intelligence, or slightly catchier, the Resect AI project. This is a partnership with us, St. Mark's, UCL, and Odin Vision, who have a good track record in AI endoscopic applications. And so far, we've had a retrospective collection of over 1,100 advanced endoscopic resections on this site. And we're using that to build an AI tool which can hopefully predict superficial and deep submucosal invasive cancer. So just an illustration of where we are at the moment. So these are 3 large rectal polyps, one of which contains cancer. And if I had to ask a novice, I think they might struggle to predict that strongly. If I asked an expert, they might have a better idea, but the cancer is in the one on the right. Secondary outcomes that we're hoping it can help us with are whether there's any residual tissue and the risk of recurrence, and also the risk of bleeding after removing the polyp. So again, going back to these 3 photos, if I were to tell you that one of these, and then their subsequent resection scars after we've resected the polyp, if I was going to tell you that one of these were to recur and one of these to bleed, I think you would find it quite difficult. I think even experts would find that difficult. This one is going to recur, and this one is going to bleed. And hopefully the AI can help us in predicting that. And finally, moving on to the procedure, I'll steal another phrase from Professor Saunders, horses for courses. So we've got a rapidly developing armory of endoscopic resection techniques now. So we've got cold snare for small, less than 10mm polyps. We've got cold piecemeal, which is increasingly used for large serrated lesions, particularly in the right colon, with good outcomes. We've got conventional endoscopic mucosal resection, or EMR, and then kind of the newer kid on the block, underwater EMR. Then we've got more advanced techniques, that's endoscopic submucosal dissection, or ESD, and then intermuscular dissection and full thickness resection. Now, the byproduct of doing this large data collection for the Resect.AI project is that actually gives a lot of information on our own performance over the last 10 years and how are we doing. So looking quickly at our workload, we can see although there was an understandable dip during the COVID pandemic, we can see that our rates of local and tertiary referrals for large polyps are back on the increase. Looking specifically at our local and tertiary referrals, we can see that tertiary referrals are more complicated. So in general, they're larger. They're more commonly found in difficult areas, such as the ileocecal valve, the appendix, and the dentate line. They're more commonly circumferential, and they're significantly twice as more likely to be recurrent or previously manipulated. So all of these things contribute to difficulty in removing these polyps. And we can also look at how our techniques have changed over the last 10 years. So you can see here the rapid expansion in the dark green, which is underwater EMR, and that's largely taken the role of the orange, that's conventional EMR. So we're doing far less conventional EMR, we're doing a lot more underwater EMR. Our ESD rates have stayed about the same. And we can also look at our performance, and in particular our recurrence rates. So you can see between 2015 and 2018, our recurrence rates somewhere between the range of 20 to 25%. From 2019 to 2023, that's more like 10 to 13%. And that may well be explained by kind of the more widespread adoption of margin thermal ablation, which reduces your recurrence after piecemeal EMR. So looking at a few techniques in particular, you can see on the right here, endoscopic mucosal resection. So this is kind of well known, but just to recap, we use a submucosal injectate solution, which expands the submucosal space and allows us to safely snare off the polyp. The advantages are it's well established and it's cost effective. The disadvantages, the main one really is piecemeal histology. So you shouldn't really be using this technique if you've got a high suspicion of submucosal invasive cancer. And historically, the drawback of piecemeal EMR was the high recurrence rates. So this used to be up to 27%, but actually, as I said, with the improvement, with the widespread adoption of margin thermal ablation, this is reduced. And actually, recently, there's some data from the Dutch suggesting that widespread scar ablations, so not just the margins, but also the scar of the base of the scar with APC can reduce the recurrence rates down to 2.2%. That's yet to be reproduced in any other centres. But there are questions remain, and one that we're particularly interested in is the injectate itself. So as you saw in that video, the injectate solution expands the submucosal layer, allowing you to safely snare away the polyp. And we usually put a blue dye in, as you saw there, which helps delineate the lesions and also helps at the end of procedure, as you can help confirm a complete resection. We also put a dilute adrenaline in, and theoretically this causes vasoconstriction of the feeding vessels, which helps with a number of things. So it may reduce bleeding, although there have been two equivocal results from underpowered RCTs looking at this. It may prolong the submucosal cushion time because the vasoconstriction prevents the reabsorption of the injectate, and it may improve the overall resection time and reduce recurrence by maintaining a clear resection field, so allowing you to see any remnants of polyp easier. But actually, its use is not universally recommended, and in the ESG guidance, it's only suggested to use adrenaline in the resection of large pedunculated polyps. It doesn't make any comment on its use in piecemeal EMR of laterally spreading lesions. So a project we're hoping to start this summer is a service evaluation looking at the use of adrenaline in submucosal injectate solution. And this will be using 3 months only with adrenaline and 3 months without adrenaline. And we're specifically interested in kind of intraprocedural measures rather than things like delayed bleeding. So does it speed up the procedure? Are there fewer instrument exchanges? So are you having to put the needle injector down less? Is it better with hemostasis, or is there less bleeding? We're using less snare tip soft coag, fewer exchanges for the coag aspirin, fewer clips at the end of the procedure. And we also want to look at how does the endoscopist feel about the procedure? So does adrenaline make it easier? Is it calmer because there's less intraprocedural bleeding? And does it speed things up? And lastly, does it help with recurrence rates? Moving on to underwater EMR. So as I said, this is really kind of the new kid on the block and something we're increasingly doing a lot of. This video here on the right is a short example of underwater EMR. So as opposed to conventional EMR, we're not using an injectate solution, but instead we're using water, rather saline, which floats the polyp away from the muscle layer, allowing us to close the snare around it without catching any muscle underneath. See, that comes off nicely in one piece. Just there. So the pros, as you saw there, it's very quick, it's very cost effective. The cons, not really yet elucidated. Now, in the published data, the complication rates are very low, but anecdotally, there are cases of deep mural injury and perforation, or at least they haven't been well described. But there are significant questions about underwater EMR as a new technique. Where exactly does it fit in our armory? So going back to the ESG guidance, you can see that right down here at the bottom, it says for large benign polyps greater than 20 millimeters, underwater EMR may be used in selected cases. And the key thing here, and the thing that we're looking to investigate, is the depth of resection. So we feel anecdotally that underwater EMR gives you a greater depth of resection than conventional EMR on something kind of analogous with ESC. And that's really important because that means you could potentially use it for lesions with a suspicion of submucosal invasive cancer. So a project that we've started with histopathology is a histological assessment of depth of resection of colorectal polyps resected using underwater EMR. So again, from the previous data collection, we've looked at all underwater EMR resections greater than 20 millimeters. And specifically, we've asked histopathology to look at the maximum depth of resection, en bloc resection rate, and the R0 resection rate. And we plan to compare this to similarly matched ESD specimens. And if we can achieve similar en bloc resection rates, R0 resection rates, and depth of resection as ESD specimens, then it really opens up underwater EMR as a quick and cheap technique for a specific subset of polyps. And that's probably those between 20 and 35 millimeters with a suspicion of superficial submucosal invasive cancer. Moving on to ESD, seen here on the right, similar to EMR, again, we're using a submucosal injectate solution. This expands the submucosal space, but instead of putting a snare around the polyp, we instead use a knife to cut through the mucosa and then sequentially get into the submucosal space and dissect it away, dealing with any vessels as they come. The pros compared to EMR, if you get a nice large en bloc histological examination, so you can accurately assess lesions that have a high suspicion of submucosal invasive cancer. And the other advantage are the low recurrence rates. It's in the region of 1%. The cons are it's expensive and time consuming. Could be anything, hour and a half, 2-3 hours for significantly sized lesions. There's high complication rates, particularly intraprocedural bleeding and perforation. And it's technically challenging with a steep learning curve. So how can we improve that? And a few things we're hoping to look at. The main one is with using new devices. So you can see here this video on the right, we're using what's called the speedboat slim knife. So rather than a needle type knife, as we saw in the first video, this is a slightly broader speedboat shaped knife with an insulated hull. So that theoretically protects you from damaging the underlying muscle layer. And instead of a monopolar current, it combines a bipolar current with microwave coagulation. And this theoretically provides you safer cutting and also controlled microwave coagulation of vessels before you're cutting them. Another device that we've been using more, and we're due to present our series of kind of the safety and efficacy of this at ESG Days next month, is the SB knife. And we particularly found this useful for these very large pedunculated polyps with very, very thick stalks. So traditionally you would inject these, put a snare around, cut through it, and hope for the best that you didn't have any bleeding. But there's usually quite a big feeding vessel in the middle of these. But we've been using this SB knife. This is a scissor type knife, which can sequentially cut through the polyp. And what you can do is you can open up the mucosa, pass the knife into the submucosa, close it, and then apply some coagulation and then some cutting current. And you can sequentially cut through these very thick stalks with large vessels with minimal intraprocedural bleeding. And then lastly, just a short video of something we tried for the first time last month, and this is a spider blade knife, and this combines the above two technologies. So as you can see, it's a scissor type knife, so it's good for pedunculated polyps, but it combines the bipolar cutting and the microwave coagulation of the Speedboat Slim. And you can see here what we've done is we can pre-clip the polyp base. Now normally we wouldn't suggest that because there's a chance that monopolar current can pass through down the stalk and onto the clip, causing damage at the base. But actually with the bipolar current of the spider blade, there's no risk of that happening. We can safely pre-clip the base of the polyp and then work through the stalk with a reduced risk of bleeding. And then finally, the last thing we're looking at, particularly with the procedure, is recurrence. So we saw from that previous data that we're getting high recurrence, getting high referrals of recurrent polyps. So overall, this comprises almost 12% of our referrals, but actually it's 15% of our tertiary referrals. And again, looking at the ESG guidance, the guidance is limited. It simply says resect and ablate areas of concern. But actually we're finding in our practice that we're increasingly using underwater EMR. So you can see that in the first 3 years from 2015 to 2017, this was only used in 9.5% of recurrent polyps. But actually in the last 3 years, the data collection 2021 to 2023, we were using it in 50%. And you can see the advantages in this here on the right. So here's a very scarred upper rectal polyp, a recurrent polyp that has been referred to as for resection. If you try to resect this with conventional EMR, you would find that after you injected, you would get very little submucosal lift. You would have difficulty closing your snare around the polyp, and you'd also have a higher risk of perforation. But actually, you can see here that by putting water in, the polyp nicely floats away, or floats away better than it would have from the muscle layer, and then we can snare it off and achieve a complete resection without resorting to ablative techniques. And then what we're also seeing in our data is we're using increasing use of combination techniques. So whether that's regular EMR, then with ablation cold avulsion, whether that's knife-assisted resection, so that's for particularly fibrotic areas in recurrent polyps, taking the ESD knife and cutting around the fibrosis before removing it. And then finally, something that we don't do much in this country, but they do a lot in Europe, is using peripheral EMR to remove the easy to remove portions of the polyp, and then using endoscopic full thickness to take the very fibrotic central area. And we're hoping to look at all of those techniques. So in conclusion, we're looking at patient, polyp, and procedure-related factors that all contribute to optimizing the endoscopic management of large colorectal polyps. That's